Good morning and welcome to Medicine Grand Rounds. I'm Bill Powderly, Chief of the Division of Infectious Diseases. It's my great pleasure to welcome to Medicine Grand Rounds this morning Dr. Frederick Altice. Rick is Professor of Medicine in the Division of Infectious Diseases and Professor of Epidemiology in Public Health at Yale University. He has spent all of his academic career at Yale, having done his graduated from Emory with his MD and then residency and ID fellowship at Yale University, where he subsequently joined the faculty and has really become one of the national, international experts in a very specific but incredibly important area of HIV research, and that is the design and implementation of programs to help marginalized patients, particularly and initially those in prison, but then because of the overlap between the prison population and opioid use and the risk of HIV and IV drug users, he has become the leading scientist in how we might develop programs to treat and prevent HIV in this context. And he's going to give a talk this morning focusing on another country, but I think something that has enormous lessons for how we might tackle problems in the United States. So I'm delighted to welcome him and hand over to Rick to give the talk this morning.
Bill, thank you so much. And it's really a pleasure to be with you, even if it's virtually. Bill and I were just talking about how the world has changed in so many ways, and I'm going to even speak to some of that in this context. And what I hope to sort of impart for you is a story of the last 15 to 16 years of work to scale up primary and secondary HIV prevention using opioid agonist therapies in the country of Ukraine. These are my disclosures and funding. The bolded grants on the right are active grants that are in Ukraine. We are going to be focusing specifically on one R01 that we've had for the last 10 or 11 years, which is expanding medication-assisted therapies. But these other three grants in the Ukraine really will be added to as I sort of lay the framework for how to scale up opioid agonist therapies. Obviously, we don't live in an island. There is a huge team of people whose lives they have contributed incredible amounts of time and energy to this enterprise, many of whom have gone on to very successful and independent careers. And I'll be acknowledging many of them throughout the presentation. So the story begins for me in late 2004 when I was asked to come over and give some advice and guidance around buprenorphine. I was the first infectious disease specialist to prescribe buprenorphine in the country. And so I had a level of expertise that they needed at the time because there was no kind of treatment for opioid addiction in the country other than forced rehabilitation. And what I learned while I was there is I stayed at this hotel in the bottom right, which is the Ukraine Hotel, an old Soviet-style hotel, and it is situated on the Maidan, which is where the Orange Revolution occurred. And you will see it really reflects the idea that unlike its neighbor to the north, that it is a country that is looking for change and is willing to make the effort to do so. And that will be reflected also in a very rigid post-Soviet style healthcare system that was not designed to do what we need it to do today. So why focus on this particular area? And as Bill said, the lessons learned here do have some great application for what to do in our own country. But one of the reasons is that the Eastern European and Central Asian region is certainly the largest region with increasing amounts of mortality and new cases in the globe. And this is in contradistinction to places like sub-Saharan Africa, which is actually have had marked reductions, their 3x5 effort and their scale up of antiretroviral therapy. But what is unique about this region is that the mortality rate has increased over the last decade by 24%, and new cases continue to increase. And this is in the absence of effective treatment and prevention. And one of the challenges that's different about this region is that the epidemic is driven mostly by people who inject drugs, with some generalization of the epidemic to their sexual partners. And so the types of strategies and the things that you have to think about might be very different than what you're doing in huge generalized epidemics like in sub-Saharan Africa. So what do we have in our HIV prevention toolbox? There's obviously a few other things, but certainly PrEP and treatment as prevention are important. And we will speak to that just very briefly, but when you have an opioid or an injection-related epidemic, your major toolkits are opioid agonist therapies and syringe services programs. And I'm going to focus specifically on opioid agonist therapies with either buprenorphine or methadone, even though as part of this work, we've introduced and done some work with extended release naltrexone, another evidence-based medication for treating opioid use disorder. And the lens through which I have done this work is through implementation science. And part of the rationale for that is that the odyssey from really good evidence, that randomized controlled trial, and even perhaps the second randomized controlled trial to show that something is efficacious until it finally gets embedded into routine clinical practice, takes on average 17 years. And this is only for the 14% of those who make it. And part of the problem is that you can either let things happen or you can facilitate it and make things happen. And that's what you can do with much of implementation science. Now, one of the problems with implementation science relative to many other sorts of areas is that it is evolving. It's relatively new. There are over 100 frameworks or models that are available, each somewhat nuanced, although there tends to be a handful of common themes. And one needs to sort of look at whether you're looking at processes. What are the processes by which change happens? Some of these deterministic frameworks that are sort of heuristics for how you sort of understand and explain how the changes happen. Some of them are just very theory-driven, based upon classic theories, diffusion of innovation, for instance, or implementation theories. And then, of course, there are some very good evaluation frameworks that are useful. And I'm going to focus mostly on the determinant frameworks. And we could spend a lot of time talking about which one to use, but I tend to use like maybe 3 or 4 of them in most of my research. And I try to use the one that's most appropriate for the type of implementation that's being done. So this is an implementation stages framework, which we started with, but we changed overall. And part of the idea of this is that you're sort of invested in this in the long run. So there's usually an exploration phase where you understand who the players are, getting buy-in and things like that. And that happened early on when we introduced buprenorphine. Remember, in this country, we've had methadone for over 50 years and buprenorphine for the last 20 or so years. So we're in a very different place as we begin to do this. Then there's the installation phase where you identify the resources, who's going to do this, prepare and train staff and understand that. And then, of course, we have some, what I'm going to go through mostly, which is some of the initial implementation and the full implementation with clear monitoring of the programs. And the framework, which we initially started with in 2010, is the Paris framework, or the Promoting Action on Research, Implementation, and Health Services. And that's been updated more recently by Harvey and Kitson. That includes some deconstruction of the evidence basis, looking at the innovation of the evidence and how it is sort of perceived by the recipients, both the ones who prescribe it and the ones who actually receive the medication. but it's broken up mostly into three different areas. The evidence, what is the evidence for your innovation, in this case, opioid agonist therapies? What is the context? And this is really a key player and really sort of sets forward the way in which we think about, let's say, for instance, the opioid epidemic here in the US. And then the other key feature that I like about this is that it's really speaks to the issue of active facilitation, which is done through coaching that's got to be appropriate. Who are the roles? Who's doing the work? What's the purpose? And do the people have the skill sets that they need? And we're going to sort of cover this sort of long odyssey over time. So if our goal in this program is to expand medications for opioid use disorder so that we can prevent and treat HIV, let's take a look at what's happened and really define the problem. And so in late 2004, early 2005, at the height of the Orange Revolution, pilot programs for buprenorphine maintenance therapy were introduced. It was too expensive. The numbers remained really stubbornly low at about 700 patients. And in 2008, methadone was introduced. And at that time, it was more cost effective, and they were able to expand their budget. And they had a plan. They had lots of money from the Global Fund and a number of other sources to really get 30,000 patients on treatment by 2015. It doesn't seem overly ambitious, but I can tell you that it was by 2010, 2011, the people who were running those programs and PEPFAR asked the question, can you help us understand why we are not getting anywhere near meeting our proposed targets? And so at that time is when we began to start to come inside, take a look at why the number of cases had really plateaued. And we began to sort of really survey the potential options and opportunities for treatment. And so the way that the medical system was first developed is that they were these specialty services called Narcology centers. And we really recognized that most of these were small pilot programs, usually in the largest cities, and there may be just one or two in each city that made it really logistically quite challenging for people to travel to. So you can imagine a city of 2 or 3 or 4 million people having one and maybe two clinics that are terribly inconvenient for patients. And so we began to think that one of the ways of doing this is to actually expand the sites or to increase the number of volume. And the regulations around this were just huge. The amount of paperwork was incredible. So we were trying to help them, and we spoke about whether we could really develop a hub and spoke system where people would get induced on treatment, stabilized, and then sent out to these smaller treatment settings elsewhere. And I will say that we've created an alternative model, which was not previously described in just a second. We also recognize that one of the potential opportunities was to provide it in primary care, but this was not legislatively allowable. But it also becomes an alternative spoke and hub type of model as well, where the spokes are these primary care services within the community. I will say parenthetically that each of these areas are one of those independent grants to sort of look at how to do this, with our trial in primary care being a cluster randomized trial of 45 sites. Pharmacies was another area that we have been looking at. We have not succeeded in being able to make any inroads into this. This could be a place like that is done in the UK, where your expansion can be more available. We've not been able to get the pharmacies to become interested, not that the legislation blocks that. And then, of course, what I call the final frontier is prisons. This particular region has one of the highest rates of incarceration. It's concentrated in people who inject drugs. And you could reduce 25% of all of the infections if you would actually scale up opioid agonist therapies in prison. And I will say, on the basis of another RO1, we have finally hit the sound barrier and gotten our first 30 patients on methadone. So we have made a small dent. We have just started, but we are on our way. But I'm going to focus specifically on community-based treatment, or what we would call typically opioid treatment programs, and how to do some of that. So what is the evidence behind it? There are multiple clinical trials and systematic reviews of reviews that really show that opioid agonist therapies, which include methadone and buprenorphine, really markedly reduce opioid use and retention relative to all other treatments, 72% versus 9%, reduces injection by 9-fold, and it reduces HIV transmission by 54%. We also know that it impacts the HIV treatment cascade at every single level, and I will show you data from Ukraine that we generated to really document that. But it also has a number of other secondary benefits, such as reducing overdose by 3 to 4-fold, reducing death, reducing crime. It increases engagement in care along the cascade, as mentioned before. It improves employment opportunities, health-related quality of life, and social functioning, and is really quite cost effectiveness. So as we were beginning to do our sort of exploration phase, Sabina Alistar from Stanford and that group did a really elegant study which looked at, in the setting of a low or middle income country that has limited resources and an epidemic that is driven by people who inject drugs, what are the most effective and cost-effective strategies in order to reduce HIV transmission? And so this modeling study used some parameters that I would say were, slightly off, but essentially the findings are probably pretty much spot on. That you can see that that if you use a single intervention like methadone, having high coverage, which they defined as 40%, would actually result in the most amount of HIV infections averted relative to treating with antiretroviral therapy. They were similar, but certainly the methadone was superior. And what we do know from prevention is that combination prevention is usually much more effective. And so on the right-hand side is the combination of high methadone coverage and high treatment. Now, and it makes sense. You basically do both of these things. And we know that if you treat with methadone, people with HIV are most likely to have better treatment outcomes. That cascade of care data had not been documented at that point, which lends more credence to this particular model. But what you can see is if you apply the cost effectiveness metrics to this, obviously the combination prevention is really effective at $1,000+ for every HIV infection averted. High treatment antiretroviral therapy, just by virtue of the cost of the antiretroviral therapy, even generics, was really 4 times higher than just scaling up with methadone. So if you have limited resources, the first step would probably be to scale up methadone, and that's followed by adequate access to treatment. Let's move to the context, and this is where the rubber hits the road oftentimes in implementation science. And so we're going to look across a number of different levels that include the individual clinics, the healthcare system, and the policies that sort of undermine or can facilitate your scale up of an evidence-based intervention. So Ukraine is in the midst of a really volatile HIV epidemic. When we first started, it had the highest HIV prevalence in the entire region at 1.2% of all adults. More recently, Russia, that has no opioid agonist therapies at all, has actually exceeded this amount. But there are, on average, about 17,000 new infections. It's concentrated in people who inject drugs, and the epidemic is transitioning to their sexual partners, and there is an increase in sexual transmission among men who have sex with men. So it is primarily remaining in key populations. It has a siloed healthcare delivery system, what is called the Shamasko system of primary, secondary, and tertiary level care. This has been in place since the 1920s throughout all of the former Soviet republics, and there have been some changes, Ukraine being one of them, that has begun to move from that. Addiction treatment is really embedded within a specialty group that looks like either addiction medicine or addiction psychiatry. It's called Narcology. And for those of you who try to type this in, you get an autocorrect that makes it necrology, which isn't such a nice thing, but it sort of speaks to the way that it's perceived both in Ukraine and through the region. And buprenorphine was introduced in 2004 and methadone in 2008 And what's really important is that the people who are the implementers, these narcologists, these addiction treatment folks, these doctors, are the ones who are supposed to implement a strategy that was not introduced for addiction treatment. In fact, they didn't believe it worked for addiction treatment, but it was introduced for harm reduction to really make an impact on the HIV epidemic. So the implementers themselves were not the infectionists, although there was some change where we developed some integrated care clinics where some of this work was moved to HIV and TB centers. When it was introduced, there was great fear about it. There were incredibly rigid regulations called Order 200 that I will refer to. This is a policy issue, and it oversees these issues. And a number of the original tenets of this is that it required daily dosing 7 days per week, no matter what, and forever. They had to have failed 2 attempts at detox and residential treatment before they would even be considered. So it was a treatment of last hope. And then we did learn that based upon some of the data that there was some healthcare reform that allowed for some new opportunities, which I will talk about briefly. So one of the things that's important is you have to have your metrics. What is it that you're going to want to improve? And for those of you who do HIV work, the HIV treatment cascade is really well defined, and it's a way to begin to sort of meet your deficits. It gives you a metric by which you want to make some improvements. And the 240,000 or so people with HIV in Ukraine, we see that the targets need to be according to the 90-90-90 rule, and it's been sort of updated to the 95-95-95 rule. But you'd want to get at least 90% diagnosed, 81% on antiretroviral therapy, and 73% suppressed. And you can see that for these metrics, it is way under where it needs to be. In a few moments, I'm going to show you some data that we generated from Ukraine that shows where opioid agonist therapy actually markedly modifies this for the entire country. But what we also decided is that there needs to be an opioid treatment cascade, and we've worked very hard to try to come up with this. And the devil is in the details, but the number of people who are registered who primarily have an opioid use disorder is only about 17% or so. So it's incredibly low. And if that is your worldview, that is all of the patients that you believe have opioid use disorder, because that's what's required in order to get treatment, it looks like you have 25% coverage. But if you look at population-based estimates, it's only about 4%. And then, of course, among those, about 3.1% of them are abstinent within that group. I will say that there have been a number of people along the way that sort of helped introduce the program. Doug Bruce, who was my postdoc at the time when we first started this, is now a full professor at Boston University. And Lori Sela, who is my program director, is now the head of the EATC, which is the Education and AIDS Training Program for the Northwest part of the country. And they worked very hard to help us introduce and scale up buprenorphine, and to introduce for the first time the integration and co-location of services, because the parallel epidemic of tuberculosis is also incredibly high in this group. I won't go into some of those findings, but just suffice it to say that that is one of the places of expansion in our research. So here we were in 2010, we were sort of asked to identify what the issues are. Why did the scale up plateau? What were the factors that were sort of impeding the scale up? And so we were asked that question. We put in the first RO1, and we used an implementation science framework to do that. And the first step of sort of understanding what were the barriers really involved focus groups in 5 major cities. We recruited 199 people who inject drugs. We used random sampling. We looked among the roles of people who were on opioid agonist therapies. We also went to the roles of people who had dropped out, and we refound them and we interviewed them. And with the idea that those were people who actually were able to drink the Kool-Aid but decided they didn't like it. And then those who had never been on opioid agonist therapies, thinking that these were many of the new opportunities. We also did a number of qualitative interviews with the narcologists and the administrators and NGOs that partnered with them to understand what were the factors at the clinic level that may be important. And we used those findings to create structured surveys using random sampling once again of over 1,600 people who inject drugs within Ukraine. And what I will say is that there's a number of papers, most of them qualitative, at least initially, where we sort of identified a number of these barriers. Martha Boyko in the upper left is now a leading consultant to NGOs across Ukraine. Ruth Ann, who was coordinating a number of the efforts, is now leading a branch at the CDC. In the center is Ilona Mashnaya, who just finished her PhD and is starting her postdoc with me this year. And in the bottom left is Yulia Makarenko, who is doing her PhD in McGill, and then Sergei Filipovich, who is doing his PhD in Germany. So it's really suggested these people who are on the ground doing this work, it creates a pathway to their own independent careers. And it's been a very exciting part of this work, having people who are invested and interested and moving forward with their own careers. But what we recognize from all of these findings is there was incredible myths about methadone, which is not unlike what we have here in the US, both at the patient and the provider level. Remember, the narcologists were the ones who were not drinking the Kool-Aid either. They thought it was ineffective. They talked about it as a death sentence. And it's true that 45% of the patients had HIV and they did die, but unfortunately it was consequences of their untreated HIV and not other causes that were opioid related. And it was perceived because of these two induction requirements that it was a treatment of last resort. There were also incredible concerns about sustainability. These international funding agencies provide funding for 2 to 3 years at a time. And so there was this perception that why scale up if we're going to have to discontinue all of these patients? There were all of these names-based registries. That is, you had to be registered as a person who had an opioid problem. They use a much more negative, pejorative word for those patients. But this resulted in restrictions. If you got registered, you'd lose your driver's license or you couldn't get one. And you were restricted from a lot of jobs, which involved construction, which is where a lot of these patients were working. And so that was one of the major barriers. And your name could be released to the police. And we have found that that was a direct pathway to being harassed by the police in a number of different settings. There was also a fair amount of organizational inflexibility. These are people who lived under the Soviet rule for 70 years and they loved rules, and they were unwilling or unable, at least in their own psychology, to be able to come up with some flexibility, although I will talk about some notable exceptions. There was the perception that the providers were paternalistic. They would mistreat the patients. They would ignore advice that was given. There were long waiting lists. This Order 200 was impossible for patients to get through the process. There was police harassment. You can imagine that if you were underpaid as a policeman, your best way to find people at the end of each month is to go find them at their sort of point of entry to the drug treatment program. It's like the watering hole for the great hunter. And also patients were not being treated with adequate doses, so it was resulting in lower efficacy. And so the perception about the treatment as being effective was undermined somewhat. What's happened more recently is we have sort of put and built this framework from all of this combined research to come up with a socio-ecological model, recognizing that there are interventions for the individual, there are interpersonal activities, families, friends, peers, organizational factors within the clinics, the community itself and the availability of NGOs and partnerships, and then of course a number of public policies. And we recognize that each of them impact each other, and part of our implementation work has been to provide these data to the various different stakeholders every 6 months when we're in country, and to be able to give them feedback so that they can actually alter the policies. And you'll see that that happens over time. I will say that when we started this work, we did this even despite the conflict. Once again, I came back to beautiful Ukraine in March of 2004, and on the day that I arrived, Crimea, that there was the Maidan revolution. You can see in the upper photograph, those are Molotov cocktails that were being created right there. Many people had already died. From my hotel where I stay at the Ukraine Hotel, it's an old Soviet-style hotel that I can stay in for $36 a night, but it is right at the Maidan. Was a place where the snipers were shooting at people in the field, and buildings were devastated, but nonetheless, the people stood strong. What did we find when we went to the surveys to sort of understand the barriers is the willingness to start was low, but if they had more positive attitudes, the family was supportive, and a number of other sorts of things that we would find some differences. And remember that Ukraine is a large country. It's like the COVID response. We have places that respond to social distancing and other sorts of policies, and places that do not. And it's no different in Ukraine as it relates to the way that patients perceived opioid agonist therapies, suggesting that you may have to have differing types of change projects or interventions at differing types of places from an implementation perspective. We also learned an important lesson is that patients were willing to pay for opioid agonist therapies, which opened up possibilities later when we changed the Order 200 to allow patients to get it outside of these narcology centers. And there were a number of factors. And the amount of money that they were willing to pay to not be registered, for example, was really substantial and enough to really cover treatment. And so some new models of self-pay treatments have emerged within Ukraine, and it's unclear where that's going, but that is certainly one of the emerging models that happens in an economy where the constraints are limited, that is treatment. And these are some of the folks on the bottom is Irina Piccolo, who now is the director of one of the research institutes, and Anna Metelyuk, who overruns this project now. And you saw Alona and Yula, but Alexei Zelenev is a computational sociologist who has been sort of working on a lot of this stuff as well. And in fact, one of the things that he did was he tried to understand the hierarchy of the barriers because there were so many, and created a scoring system. And what we really found is that the logistics of the program and the program entry characteristics and what we call demand characteristics, as well as the treatment attitudes about whether it worked, whether it was safe, whether it was detrimental to the patients, really accounted for 82% of the barriers. And so this was the place where we began to do a significant amount of our, what I call our change projects. What we did do, and this was before the systematic review was published, but we actually created the cascade of care among people with HIV who were either on OAT or not. And as you can see that it is significantly improved for each patient who is on opioid agonist therapy in terms of their being diagnosed, linked to care on antiretroviral therapy, and adhering optimally to the treatment. And we've extended this further and also show it for viral suppression. But what's really important here is that among those 90-90 targets, for the first time in a place like Ukraine or many lower middle income countries, is that at least among patients who are on opioid agonist therapies, 90+% of those patients are diagnosed. So it really provides an opportunity, and diagnosis is the first step of the cascade. We did find that, however, we had a big gap in terms of antiretroviral therapy, and that has been one of our change projects to sort of focus from diagnosis to sort of initiation of therapy within 7 days. And Ilona Mezhnaya is the person who published this paper and did a really excellent job, and who just finished her PhD. So that was our sort of exploration and installation phase, where we sort of understood the lay of the land. And then we moved to the next phase, which was our facilitation using something that's called NIATX. And NIATX is a treatment improvement process that's based upon collaborative learning, which is an innovation for Health Institute sort of recommendation, and recommended by the Institute of Medicine, or now the National Academies of Medicine. And so, and it's specifically targeted for behavioral health, for mental illness, or for substance abuse treatment. And what we do know is that in the absence of facilitation, on average, it takes 17 years for 14% of the interventions to make it, that is letting it happen and maybe helping it. But with active facilitation, you can actually move that much more rapidly so that 80% of the interventions can make it within 3 years. And we talk about the 3 to 5 year range for many of these interventions. So our conceptual model for this was actually really quite simple. We basically said we've got this group of people with opioid use disorder and who are people who inject drugs, and that is the potential for patients who can get on therapy. And then one of the things that happens is what I call an arbitrary constraint called capacity. And that is that you set a limit on how much medication that can be purchased. And certainly the capacity was not limited, but it was sort of artificially imposed based upon what was perceived to be the amount of medication. But I would say that because it is a mutable number, that you could actually have as a change project just to change the proportion of patients. And that was one of our change projects later on. But that the dynamics were mostly defined by entry characteristics. Could you get more people to drink the Kool-Aid, if you will? And were you doing a decent job with keeping them from dropping out? And so your capacity is either maintained if you have entry versus attrition being the same, or not. And if you can block the attrition or increase the entry, you can actually increase your capacity, which was our basic framework. And I'm not going to present all of the fancy statistics and stuff like that. I'll just show you graphically later on how some of this works. And what we had to have is we had to have some sort of evidence-based, or I shouldn't say evidence-based, but some sort of database so that we could actually measure this. And we reinforced the CyREX database, and the Ministry of Health required that every patient who was prescribed opioid agonist therapy in the country had to be part of this database. So we've got a really good way to measure this, and it is updated monthly. And it includes a number of the patient characteristics, where they're getting their treatment, what is their dose at that particular time, so we can look at some of the quality indicators, and if they dropped out, the reason for dropout, although those dropout reasons were variable. And one of the things that we learned when we first started was that these entry and attrition characteristics changed quite dramatically by region. We had some regions that could put 100 patients in a month, but they would lose 100 patients. So they were staying quite stable. We had other places that I called them the stingy sites. They kept everybody there, but they didn't let anybody new in. So their attrition was low, but their entry was also low. What we used as part of our active facilitation with this model is just to sort of set the stage for you. It's a facilitation model of process improvements. Remember, these processes are keys to implementation science that are specifically for behavioral healthcare settings. And its goals are really to reduce waiting time. So if you've got a waiting list, to decrease the no-shows for that, increase the number of admissions, and reduce attrition. So all of those are key factors for scale up. There are 5 principles, that is, understand and involve the customer, a walkthrough. What does it look like to be a patient? And we'll talk about some flow charting in order to get at that. To fix the key problems, in other words, do you want to fix the attrition problem? Do you want to fix the entry issue? All of those sorts of things. One of the painful lessons we learned when we first started is you have to pick a powerful change leader, and we did not necessarily have the right ones, and we sort of moved eventually to getting the chief narcologist or the chief administrator for addiction treatment in each region. Get ideas from outside the organization. That was us oftentimes, but we also brought in others. We also made site visits to the US. And the key element of this is these rapid cycle testing to document whether you have a change. And we would try to set this at, sort of the maximum of a month's time to see if we introduced a change, whether it worked. Lynn Madden, who is now a postdoc here and who is joining the faculty, has been leading a lot of the NIATX and Scott Farnham has been one of our coaches as well, and I am now a NIATX super coach for whatever that means, so that I could learn the lessons that my research team was doing. Here's the model that sort of moves patients to better treatment, and it uses these rapid cycle change projects, plan, do, study, act, which is common in quality improvement projects. These are the groups of chief narcologists throughout the country. This is our large learning collaborative. One of the things to recognize is because you think about these oblasts are states, and every one of them has slightly different attitudes and approaches to how to do this. And so we use this as a collaborative learning environment to help each other, teach each other about how to improve some of these things, because one of the things that we learn is that when people feel comfortable in making changes and they don't get harmed, this is a punitive society, then the others are willing to make those changes. So what does it look like? So part of the work that these chief narcologists did with patients is they said, what does it look like from a patient perspective? And so we created this odyssey to treatment. And so first of all, the decision to start opioid agonist therapy had to be made first, and we're doing some work developing some decision aids. They then had to go through 2 detoxes. Any patient with opioid use disorder, the one thing they fear most in life is detox. They then have to return to the clinic again if they failed a 3rd time, which was happening in 90+% of patients. They would then have to go, after their sort of initial application, they'd have to go to a medical doctor and get an exam. They'd have to go for a TB visit to be ruled out for TB. And they'd have to have a laboratory assessment, all of these came out of their own pocket. They would then have to return back to the narcology clinic. And then if they were sort of started, they were given daily supervision for essentially the rest of their time on treatment. So you can imagine that the demand characteristics for this is incredibly hard, and scale up is oftentimes impacted by the demand on being able to use that evidence-based intervention. So part of what we began to do as our change projects, which also resulted in a change of the law, is we altered the detox ×2. We had a number of clinicians who would have the patient come in for an hour. They would detox and fail. They would ask them to leave. This is an act of civil disobedience, to come back an hour later, and then they would actually then start the entire process. So they did a facilitation process. And when we showed that that actually was not needed, we eventually changed the law so that that was removed. And then that would remove another visit back to the clinic. And then the other sort of thing is we recognize that these screenings, this medical exam, a TB visit, and a laboratory assessment, were required based upon Order 200, but it didn't say when it had to be done. And we certainly know from our treatment in general that once patients start opioid agonist therapies, their life normalizes quickly, or relatively quickly. Their ability to comply with all of these complex things like getting to all these medical appointments. The TB clinics were oftentimes outside of town by 25 or 30 kilometers. So all of this was really challenging, and you could go right from the decision to starting OAT, putting them on daily supervision, getting these medical exams done within 14 days, and then within 6 months, they could get a take-home dosing. The take-home dosing was a new pilot project that we call it a promising practice in implementation science, which then was also later used to change the rules. So one of the things that we ultimately did was we started out with these change teams that involved many community members, and that was really not effective because they did not have the power to change any of the regulations around treatment. So we brought in the chief narcologist. They would have weekly coaching calls. We had 4 coaches that were Ukrainian and spoke the language, and we would come on a Zoom meeting once a month. The change projects would have to be decided at the beginning of each month, and they would do it. And we would use the collaborative finding by bringing the groups together so that we could promote leadership and develop expertise. And I can tell you that these folks have really emerged as treatment leaders in the country. These are 4 of the chief narcologists. I will say that What is missing from this particular group are women, but you can see across here that the narcologists are probably 50-50 men and women throughout the country. This is one of the collaborative learning where people are sort of sharing their change projects, what's worked and what hasn't. And one of the things that you can see is that during our first couple of years of using the NIATX change project, we did get a bump in the number of cases, but it was really not terribly impressive. We did increase the number of patients on OAT by 64% overall, but I will say that if we remove the baseline patients who were from Crimea, remember that Crimea was annexed in March of 2014, that 830 patients were taken off the rolls of treatment in a one fell swoop by the Russian government. And so those patients were lost. So we did actually double the number of new cases that increased, but part of that was done by increasing the number of sites, but a lot of that was transfer of patients who had complex living circumstances. So we began to develop these spoke and hub sorts of models through this scale-up project. And then, so as we move forward, one of the things that we see is that there were a couple of things that we also learned from the data. And that is that the patients actually increased, but most of the increases were done through quality projects where they focused on retention. And they did that mostly by scaling up the treatment dosage, that is putting patients on an adequate treatment. And remember that 45% of these patients are on antiretroviral therapy, and the medications that they use reduce the methadone levels by about 35 to 40%. And so it oftentimes needs a much, much higher dose in order to retain patients. What we did learn is that, and these were some modeling that was done by Thomas Tan, who is now a doctoral student. He was a pre-doc with me here, and Alexei Zelenev, and he's now at the University of Michigan doing his doctoral degree. And the way that they did that was we looked at their own data, looking at retention, and that higher doses of methadone resulted in significant retention levels over 1 year, but it extends out to 3 years. And interestingly enough, unlike the international data, the retention on buprenorphine was higher than for methadone. Part of that may be the way that both of these are given as directly observed therapy. But the other important part of it is that there was a high preference, and buprenorphine was seen as a scarce resource. But what we did see, and this is a region that was taking some chances, if you will, they were doing these promising practices that would increase the number of new patients. And one of the things that you see with these blips in late 2014 and again in late 2015, early 2016, is that there was a pilot buprenorphine prescription. That is, they would have take-home doses. So that was the first time we did that as a pilot. That was approved. And our second one was take-home dosing. So we allowed for things to be prescribed so they could go to a pharmacy and they could get take-home dosing. And these are what we call promising practices that we then feed back to the Ministry of Health in order to change the legislation. That is, those things that are happening at the policy level. So using data from this, Order 200, which is incredibly restrictive, was changed at the end of 2016. It removed these repeated detoxes because we documented that that was not really effective or needed. Take-home dosing for the first time was allowed, and patients could be given 3, 7, or 10 days of medications for take-home, but it required that they have full sobriety based upon urine toxicology screening every month for 6 months. And of course, these costs for the urine drug testing was somewhat expensive, and it came out of the patient's pockets. But nonetheless, it created a new opportunity, and it could be moved outside of these specialty facilities. So it could go to primary care, it could go to HIV and TB clinics, and it could be in psychiatric clinics, and for the first time in prisons. The other thing that happened, so those were all sort of facilitators, if you will, but we did have a change that happened in 2017, and that the procurement was transferred to the Ministry of Health, who had no experience. It resulted in a very complex requisition process. and distribution logistics that were really just a bit of a nightmare. Places would start to run out of medications, and it's really hard to sort of transfer medication. So dosing would be sort of reduced over that time period. By 2019, these procurement issues improved, and they also allowed for the first time an increase in the number of buprenorphine prescriptions. They were not limited by how much they requested, but it had to be linked to their scale-up targets that were set by the Ukrainian Ministry of Health. And then the other sort of ratchet that was thrown into the mix was that, and it was based upon data that we had provided showing that that finance-based healthcare, based upon the willingness to pay, was a reality. But it also resulted in the national healthcare system of Ukraine being established, which used incentive-based financing. And the targets had to be put in February 2020, which changed the dynamics of how methadone and all other healthcare was going to be reimbursed. So phase one was that sort of somewhat continued increase in treatment. And then in phase two, we recognized that we needed to change the learning collaborative so that we needed to look at places with high amounts of coverage, low amounts of coverage, et cetera. And we created a series of sequential challenges that were based upon the data. And so the first challenge was to scale up by 20%. And the second challenge, which we're in the midst of, is to scale up to national targets for this year, but also to increase the number of patients who are on take-home dosing in order to reduce the amount of work. Now, let me just show you what happened at the results of our first challenge. This is among all the chief narcologists, and there were financial incentives. Their region would get $1,000 if they did this over a course of a year at the highest level, and they could get $500 if they sort of partially met that sort of goal. And what we did was we had a number of regions who had very modest increases around the country. We had others that got in the 10 to 20% increase, so they didn't actually meet the target. But we did have 7 or 8 regions that actually scaled up by more than 20%. And one of those regions in Donetsk, you can see in the far right, that's one of the Donbas oblasts. And so it's got conflict. And they did that despite the conflict and the sort of the ongoing war that's going on there. And we did have one region that scaled up by 71%. So this is a clear leader. And I can tell you that these are many of the chief narcologists who are the innovators, if you sort of look at a diffusion of innovation sort of theory. The other thing that they did was the minute that they were allowed to change to take-home dosing, we see that there has been an ongoing increase. You can imagine this reduces the amount of work that you have to do if you can give somebody their medication for 10 days. So they work very hard to get patients on to take-home dosing. And so you can see these sorts of curves in phase one, where it's increasing, and it is successful, but I'm not sure that it's any different than it was before. And then once we removed some of these obstacles by using the data to do that, we see that the slope of the curve, and we did the math on the slope of the curve, this is really quite significantly different, and it was based upon these change projects. Now, I will say we've learned some other sorts of things as a consequence of COVID, as we all have. The world has changed. I'm giving grand rounds, not in person. I'm going to be buying my own lunch here as opposed to having lunch with you all there. But these intertwined epidemics of COVID-19, opioid epidemic, and the HIV epidemic have all become intertwined when the Ministry of Health issued guidance that said you need to move as many patients as you safely can to take-home dosing. And what you can see here is that you want the oblasts to change from the red and the purple to more of the yellow and the green, which is what you see that's happening here, with a few places that don't really change that much. Crimea is at the bottom because there's no opioid therapy. And what you can see is that most of the patients went to 10-day dosing, and they went from 53 to 84% of the patients getting take-home dosing. And what that would result in, if they continue at this level, is it would result in a difference of over 1 million contacts between a patient and a clinician over the course of the year. Think about what you have in terms of additional time that you can do other sorts of things like, teleconferencing, to educate patients, to do counseling that you can do very effectively. And that translates, if you have 5 minutes per visit to come take the medication and have it observed, to 84,000 hours of saved time in work. And one of the things that you are concerned about whenever you sort of change and make things more available with a medication like methadone is the big concern is around diversion and overdoses. And one of the things that we did was when we looked at the annualized mortality rate in the 2019 year, it was 4.3%. It was 5% in the 3 months before the guidance was issued, and it stayed about the same at 4.2% for the last several months since then, really suggesting that we were able to provide benefit. We were reducing the nosocomial risk of transmission because these patients take public transportation, but they did not have an adverse consequence of that. So just sort of getting to the point of being able to summarize up a little bit, these are the data looking at how to scale up opioid agonist therapies in these settings. We've also, when the laws changed in 2016, we developed our first 3 pilot primary care integrations. We learned a lot from that. We have translated that into a cluster randomized controlled trial of 45 sites and 1,450 patients that is underway right now. And we are looking at quality health indicators to really suggest that it's not just the opioid outcome that's important, because patients with substance use disorders on average die 23 years younger than their otherwise matched controls in the community. And so we're looking at some of those indicators. I can tell you the preliminary data is looking pretty good. And then we also built in a fee-for-service where there is a pay-for-performance for clinicians who achieve these quality health indicators as a third arm within this study. And then we've had some another project where we're just starting in the prison. So if I can just summarize, implementation science is an effective strategy to introduce and scale up evidence-based services. But I will say that it requires a structured process of understanding the landscape, if you will. Some people call this a gap analysis, a landscape analysis. But early implementation and eventually full implementation should be guided by the framework. And the lessons that you learn should be fed back in order to change the policies. It's complex, it's dynamic, and it often involves changing multi-level factors along the way. And NIATX can work at entry characteristics, attrition characteristics. It can work on the healthcare system changes for the patients. So it has that flexibility in terms of being able to have a unique process for each particular site. And unfortunately, it's likely to be slow, but with effective facilitation, which there was a learning curve for us, it can actually speed the process. I'd like to sort of acknowledge that I've not been able to go to Ukraine for 6 months. I'm on Skype calls with them as I am with you, or it's not Skype, but Zoom meetings now. And I dearly miss the work that's being done, but what's really quite gratifying is that they continue to do the work and they continue to succeed despite a number of ongoing impediments. Thank you very much.
Thank you, Rick. I think it was a tour de force in terms of how you take implementation science in a scale to a country. We have a couple of questions already, and I just invite anybody to write their questions in the chat if they have. The first is that many of the advances appear to involve bypassing problematic regulation by providers. How do you prevent backlash from the government or from the authorities to overcome or in that setting?
That's completely legitimate. And, you know, I will say that having worked there, I've been through probably 3 or 4 presidencies, a couple of revolutions, and with that changes the Minister of Health. I would say that one of the important things that has been sort of a mainstay is that much of the support that comes from global international donors has been really helpful in sustaining at least some of the momentum, even though we might get a Minister of Health who is completely against medications for opioid use disorder. These international donors, like with PEPFAR, just having a presence in the country has been very helpful. And so we've utilized that. And then Global Fund is a place that provides a huge amount of money for HIV prevention and treatment. And Ukraine has been one of the places that is not being phased out yet. So that, I think it's been helpful. My biggest concern, which I think completely relates to this, is that if the international funding were to disappear, I think that we would see some backlash from this, which is legitimate. But the other thing that's happened is I think that we're now at the 15-year mark or so where a lot of these things are institutionalized. Medications for opioid use disorder has changed much in the eyes of the government, the patients, the families, et cetera. And the one thing that we've not done is a better social marketing campaign. But I think that we're probably stable, but we could fail in our scale up if some of those things should change. And I think that's a legitimate point. And that's one of the challenges with implementation science. You've got to really keep your eyes on all of those elements within that sociological model in order to sort of think about what's happening at one time. And it's not just one thing, it's oftentimes many.
So we have one other question before we wrap up. The question is, how was the decision to select buprenorphine or methadone made? What factors favored one over the other? In the United States, as you know, having to go to a methadone clinic can be a significant barrier, particularly in the more rural settings.
Yeah, so Ukraine was slotted to start with methadone initially, and there was all of this fear around overdoses and all of these other sorts of things. And buprenorphine was appropriately perceived as a safer option, although we knew that it was not going to be quite as effective with regard to retention. So that was the first sort of thing that happened, but that ended up being a sort of a window of opportunity. Didn't happen fast enough, but they learned very quickly that they just couldn't afford it. It was more expensive. And then what's, I think, really happened that's driving a lot of the other work, and I didn't present it, is that there are very clear preferences that patients have towards the type of treatment. And one of the things that we've been developing for the US, and we're actually in beta testing, and we're just doing the alpha testing in Ukraine, are these patient decision aids. And we're creating some of them as informed decision aids and some of them as shared decision aids. And so when you have an array of options, patients are more likely to choose something if they have the appropriate information. And so the decision was sort of done in reverse compared to most countries. And now we're at a point where both options are increasingly available, and creating those processes where patients can have sort of a less restrictive access to the treatment, I think will be good for some patients and not for others.
Rick, thank you very much. We're past the hour, so I will close things, but I want to thank you on behalf of everybody in the department for really a tour de force. Thank you very much.
Yeah, thank you so much for inviting me. It's always a pleasure.
Well, I think we're back to you.
Yep. Thank you everyone for joining us for Grand Rounds this morning. Thank you, Dr. Altice and Dr. Powderly as well. We'll go ahead and conclude the series today, and we'll see you all next week.